Sounds good.
Okay, you ready?
Yeah.
Okay. Good morning, everybody, and welcome back to the KCCMH Connection podcast. Today, I'm here with Bre Carlson, a registered nurse with the Park Health Rural Clinic. And so, Bre, tell us a little bit about yourself, how you became an RN, and if Park Health is different than Kit Carson County Memorial Hospital.
Ooh, good question. Okay, I'm Bre. I actually went into nursing because I thought I wanted to be a labor and delivery nurse after I saw my best friend have her son.
Okay, you saw her have him?
Yes.
And you wanted to be part of that?
Yes.
Okay, all right.
Got into nursing school. I did a lot of like elderly care, senior care, home care as a CNA, and then went into nursing school. Got into my labor and delivery, what's it called? My labor and delivery clinicals. Mm-hmm. Labor and delivery is not for me. So I finished up nursing school, and by a wild hair, my original capstone, which is like your senior practicum, your last kind of shadowing and your last credits, got canceled last minute. And I had some connections, and I actually did my capstone with a really, really small hospice in the city. Just starting out, it was one nurse and me. So that's kind of where I hit the ground running. But yeah, that's me. That's kind of how I started. And
Okay.
I would say the clinic versus the hospital, I don't have a good answer for that.
Well, I know that sometimes we just use the term Kit Carson County Memorial Hospital, but it's all encompassing. So what are the main duties of your building across the street, Park Health?
Yeah. So we see a lot of acute illnesses. We also manage a lot of chronic illnesses, primary care from birth to death. So that's kind of our primary role at the clinic, is the acute care, the acute illnesses, the chronic care, chronic management, and then we encompass the whole entire lifespan.
Yeah. And I know that you specialize in home health services. So what does a day or in the life of a home health nurse look like?
Yeah. So a lot of people know that our original home health and hospice that was run through the hospital closed a couple years ago, but because we are in the area that we're in, rural and critical access, it allows us to run what service I run, which is the visiting nurse service. It encompasses the same work as home health and hospice would. It unfortunately doesn't have the auxiliary services that a typical home health and or hospice that you would have in the city has. So right now, it's just the skilled nursing piece, but the same type of work. So in-home wound care, in-home PICC line care, IV antibiotics, medication management, teaching. End-of-life care is obviously a really, really big one. So that's kind of what I do. Same work, just different wording, now that it's the visiting nurse service.
So who can be one of your patients?
So I can take any patient that is a established patient at Park Health, and one of the requirements is to be classified as homebound, and you have to require skilled nursing. So like the things that I just talked about, we'll get some swing bed patients out of the hospital that just need a little bit of extra teaching, monitoring, just making sure they're kind of getting back to that new baseline. I take patients that are coming out of the hospital for end of life. So it really, we can make, if somebody needs skilled nursing and needs that extra care, we can make it work.
That's amazing. And so it sounds like you work with some very vulnerable populations when they're in vulnerable moments of their lives. What does that responsibility mean to you?
It means a lot. I look at every single patient as my own family, and I take that very, very serious. There is a huge, diverse population that we work with here in our community, and low income, there's houses that you have to go into that aren't the cleanest, and then you're going into $1 million homes, and they all need the same care. So that's really important to me, is just to go into the situation, figure out what this patient needs, and deliver. It's going to look different for every single patient, but
Sure.
just providing that respect, gaining that trust, and you are responsible for walking them through such a huge piece of their life, especially when it's end-of-life care.
So talking about end-of-life care, we did briefly speak with Nurse Nicole about
Yes.
that. But tell us, I know that some people say the word hospice, which is like a brand for end-of-life care.
Yes.
So tell us about what your responsibilities are, or what end-of-life care looks like here.
So I really like to have individuals, and the reason that I like the way that the visiting nurses service is set up is I work really closely with all of the providers at the clinic. And so if a provider has a patient where they're like, they really have been declining, their new baseline is a lot lower than they were. They're at end stage disease processes, and we can start those conversations early. I love having those conversations early because you can create a bond, you can create a rapport with these patients. They may not be on service, but I can go into their appointments at the clinic and just continue those conversations as to what's going to come next. What is this going to look like for you?
So that sounds so scary to me. Like, if having that conversation with somebody, is it really tough?
No. For me, no. I'm very comfortable in this work. Every patient and every passing looks different, and their needs are different, but I'm really comfortable in the work that I do and the knowledge that I have. And so having those conversations, for me, it's important to just be honest, but also be humble. Like, I've seen a cancer death. Cancer deaths are very similar. Their decline is very similar for any patient. But just continuing to be humble that it may be different for this patient. And that's where I get my challenges, is this would typically work for one patient and it may not. So constantly learning the patient early and knowing what's important to them, what their wishes are, is also really important to make sure that we're treating them as a whole person, and not just their symptoms.
And do you feel like having those conversations early helps both the patient and the family prepare for that transition? Or
Yes, I do. It is a very difficult conversation. I think it's important that I am comfortable with the conversation because it's an uncomfortable conversation to have. And for families and patients, it may be the first time they're talking about it. So I think, tell me what your question was again.
so for people who may not understand, what does end-of-life care involve, and why is it so important for families?
Yeah. So it really encompasses the whole person, their whole life. We're all going to get to this point where we pass. It's inevitable. We're all going to get there. And so it's really having those conversations soon to discuss what is important to you. What's important to that person? What's important for that family? What do they want for their family member that's passing? What's their role going to look like? A lot here, specifically because we just have that skilled nursing piece of it. A lot of the daily care lands on family and caregivers. So it's important to communicate. This is what the trajectory could look like. Are you prepared to do that?
Oh, wow.
And here's the tools that we currently have. And navigating that, it's different for every single person. Some families are like, yes, I've got it. We can keep them home. We can keep them comfortable. I'll do whatever. For some families, they want to be a family. They don't want to be a caregiver.
Oh, I could see how that role would shift.
It's hard.
Yeah.
It's very, very hard. It's very difficult to have somebody that you love, loving them through their death, and also caring for them through their death. It's very hard to separate. And for some people, it's difficult to do that, to be that caregiver.
And it's okay for people to decline that caregiver role so they can stay family?
Yes. It's very important to and having those early conversations, you can identify within yourself, like, can I do this?
Yeah.
And it's important to take care of yourself along with your loved one, because your loved one knows exactly how you feel.
Yeah.
And they can feel that, whether they're alert or they're not alert. It's good to recognize within yourself if that's something that you're capable of doing, and it's okay not to be. That's why we use the resources that we have, and we come up with solutions.
And some of the choices that patients can make, would that be like pain medication, where they want to pass?
Yeah. A lot of, there's a negative connotation with hospice. You feel like hospice comes in, they start the end of life medications, and that's what is the demise of their loved one. But it's not. We're treating the whole person. So yes, when somebody's passing, are there typical signs and symptoms that tell us they're getting near? Is there pain? Probably. Is there anxiety? Probably. But we can discuss, what are you comfortable with? How sedated do you want to be? How alert do you want to be?
Wow.
What are the things that are important to you? And I have to be the person to say, I know this is your wish. We want to honor that wish, but here's what's coming. So let's talk about options, because what we're currently doing may have to change. And it's constantly changing. 1 minute you can be awake and eating, and the next you're not able to get up. So things change very, very fast. So having those conversations, what is important to you? Do you want to stay home? If you want to stay home, this is what that picture looks like. Longevity, I can't, even though this is my job and I've done it for a lot of people through the end of their life, I can't tell you how long it's going to be. So the longevity piece is another tough conversation.
I bet.
For those families and patients that have said, I want to stay home, this is where I'm comfortable. It could last months. And can you handle that?
Oh, wow. Do you feel like that you often become emotional support for?
Yes. And that's a huge part of my job. I'm not just treating symptoms, because that portion can relatively be easy. We have medications to treat those symptoms, but every patient has a history. Every patient has lived a life. Every family has dynamics. And so you're coming into a situation with multiple family members with different opinions and a patient they love.
Yeah.
So taking all of these different opinions and all of these emotions, because it's so emotional, and bringing it back down, focusing on this patient and giving the patient, sometimes they just want to talk. Sometimes I don't have to go in, they're anxious, I don't have to go in and be, here's some Ativan, here's some morphine, this will make you feel better. Sometimes it's literally sitting there and being a human and having a conversation.
Oh, that's so special.
Yeah.
So I could feel like that could lead to a lot of your own emotions, or, we always talk about nurse burnout, because I think you're a one-woman crew in your department. What do you do to de-stress or keep yourself from feeling overwhelmed by that job?
Through the work, you unfortunately learn to be desensitized. There are situations that are harder than others, and that comes with the job. Just recognizing that within myself is probably the most important tool in my belt, is just knowing, okay, like, I'm tapped, I need a little break, and just finding things outside of work to refresh, and just being honest. I can call, I've got a couple nurses, Kendra specifically, I can call her and run a difficult case by her, or just say, hey, like, I've had a really difficult, and just hearing, like, it's, you're good, you've got it.
Yeah.
And then just resetting in ways outside of work is important. We'll have busy seasons where I have multiple end-of-life patients at the same time. And then we'll have some seasons where I don't have any end-of-life patients. And so I just really try to prioritize when I have that downtime, just to make sure that I'm taking care of myself, so that I can be the best for my patients.
That's great. So kind of shifting back into more of the nursing side, what are some of the biggest challenges of providing care in a rural setting?
I would say rural setting would probably be the access to those auxiliary services. So if you're up in the city, you have a CNA, you've got a chaplain, you've got a social worker, you have volunteers, you have the nurse, you have a ton of resources.
So you're not talking about things, you're talking about people,
Yes.
support staff.
Yes.
Okay.
Yeah. When it comes to end-of-life care, we don't need a whole lot of things. We've got donated equipment that we're able to provide families while they're on service with us. And so that piece is taken care of for them if it's something that they need. We're constantly assessing how can we keep this patient as functional as possible with where they're at. So, we can get hospital beds delivered. We've got commode, any equipment that you can think of we have, but we don't have the people. So because of the visiting nurse service, it doesn't allow us to have a CNA on staff to help with bathing or feeding.
Oh, and that's just the nature of probably billing or insurance or something like that.
The
that
program.
You can't have
And we're working on that. That's something that I think is really, really important and would truly help a lot of these patients and these families, is just taking even the caregiving piece, that, mom giving or daughter giving dad a bath. A lot of people aren't comfortable with that, and there's only so much that we can do. I have been able to pull some resources in the community, and I have a list of private paid caregivers because we do have quite a few throughout the community. So that's been really nice, but it's something that I am working towards, is being able to employ an actual CNA or caregiver to the team. So I would say that's probably the biggest challenge of providing care in the rural community, is the people.
Yeah.
In terms of supplies, any home health nurse or hospice nurse knows that you don't have everything at your fingertips. So you have to become very, very creative and think fast on your feet to be able to provide the care that the patient needs with the resources that you have. So that's a big challenge. If you've worked in the hospital, you have all those resources, you have your people, you have every medication you could need, you have every supply that you need for these patients. You don't have that at home.
Right.
You're in your car, you're going down the county roads for miles, you lose service, you're in this home, and you got to make it work. So you have to be really crafty.
Oh, well, that's probably fun.
It's a fun part of my job.
Yeah,
it's
that
very fun.
problem-solving piece.
Yes. It's one of my favorites, honestly. It's just thinking on your feet and still being able to provide really good care for these patients.
I love that. So that's the challenging part. What's some of the more unique or very cool aspects of rural nursing?
It's the community. I feel like we have an extremely tight-knit community, and when someone needs something, people pull together.
Yeah.
And you don't necessarily get that in the city. The city is very impersonal. It can be very impersonal. And so a rural community like ours, word of mouth, the churches, this community is just incredible. And it's nice that we have providers that know their patients, and they probably know their family members. Yeah. And so it feels personal, it feels connected, and it's not just another person that's passing. It's some that we know them. Yeah. Somebody knows this person, and they've had an impact in this community, and so it's an honor to care for the people in this community, and how the community pulls together for one another. It's really special to see, because you don't get that in the city.
Yeah. So what are some of the things that you do with patients and family to build trust?
I think it's just those, initial conversations, and just really being able to feel out the dynamics. It's important to learn the family dynamics, and the more you visit and the more you just sit down and have conversation about, what did you do? How many kids do you have? Just getting more of their history, and not just going straight into, you have a terminal diagnosis, here's what's going to happen. You have to pull that personal side out in those conversations so that you learn what's truly important for these patients.
So just taking the extra time to get to know them as a person before a patient?
Yes. I can treat anybody's symptoms, but treating a person is completely different. We all have symptoms, but if I don't treat you as an individual with the life that you've lived and the diagnosis that you have, emotional taking care of somebody's emotional state and their emotions is a huge part of what I do.
I can imagine. But I will tell you this. If I need end-of-life care, I want you to hook me up to an IV of coffee.
Coffee?
Yeah.
Okay.
Just...
All right. We're hyping you up through the end.
Yeah, it just brings me peace.
Okay.
So, what is something that you wish people understood more about the work you do? Not just end-of-life care, but the home health. Are there some misconceptions, or is there something you really wish people knew?
That I'm available. I think getting the word out that I'm available in the community, because we have such a lack of resources, that somebody doesn't have to go up to the city and die. That we have options to keep them home. We have options to treat them here and keep them comfortable. And things change. The work that I do, it's important to start early. Like I said, we're all facing the same end. Everybody's is going to look different, but just kind of having those discussions more openly instead of viewing it as so taboo, because it truly is something we are all going to experience at one time. And the more conversation we have about it, similar to mental health, the more we talk about it, the more comfortable it gets to talk about. So I think that that's a really important part of the work that I do is starting those conversations early to make it just a little bit more comfortable for people to process and work through. There's a lot of pieces that go into this. I had my own personal experience. My dad recently passed, and I was his nurse, and I thought I had everything ready to go. Nope, I sure didn't. We thought we started early enough, and I don't think you'll ever really be prepared, but starting it as early as possible and having those conversations to prepare is really, really important. And I want to advocate for my patients and families to start that stuff early.
Wow. I'm sorry to hear about your dad.
Thank you.
I think that's incredible, though, because now you have a unique personal experience that I would assume helps you relate to patients in a different way now.
Yes, it was the most eye-opening, humble experience that I've had as a nurse. And obviously, take the daughter portion out of it. As a nurse, being there with him for 8 days at home, and doing everything that it encompasses to care for somebody who is passing, and not having a break. As a nurse, I get a break. I go into these patients, I'm there for an hour. Sometimes we have to do longer visits, and we have these conversations, and I say, here's your tools, but I'm not going to be here 24/7, so I'm going to teach you how to do this, and then I'm not going to be here. Well, when you have your own personal experience, you're there 24/7, and you truly see what these families are going through with their loved one that I don't see. So it was extremely eye-opening and humbling, and I feel like it's definitely changed me and the nurse that I want to be, and the understanding of what these families or caregivers are going through, taking care of somebody that's dying.
Oh, wow. So outside of your father's experience, is there another time, whether wound care or visiting nurse or end of life, that really stuck with you?
Oh my gosh. I think every patient has taught me something. A lot of my patients, it's just humbling experiences of, here's what you're taught in school. Here's the medications and how they're supposed to work. Well, guess what? Not every patient is the same. Not every disease trajectory is the same. So what you think should work doesn't work. So you have to listen to what those patients are telling you, what those families are telling you, and try different things and not be stuck on, well, this should work. I've had a lot of different passings. I've been present when people have taken their last breaths. Every experience is one. I mean, just being a part of this vulnerable piece of life is an amazing experience in itself. I recently had a patient that had a diagnosis, was very with it. We started comfort meds, and they knew it was coming to the end, and they were able to call multiple family members that weren't going to be there and had a huge family that was present. He individually spoke with them, and they all went to bed, and he passed that night.
Oh,
And it was, I've never experienced anything like that. And so speaking to the family, I'm like, you have no idea what you just got to experience. The person being alert and able to communicate with you and tell you that they love you and that they're good, they're good to go. They've made peace with this decision and talking to individual people, and they will have that memory forever.
yeah.
That's incredible.
A major blessing.
Incredible.
Oh.
So that one definitely stuck to me. But honestly, every patient that even my wound care patients, every patient that I meet, and we spend a lot of time together.
Yeah.
So you learn a lot about them and what they've gone through in life. And again, it's treating the whole person. It's not just treating the issue.
So in nursing, I know there's a million fields. Like you said, you wanted labor and delivery. Yeah. What would you tell a nurse that's looking to change careers to convince them that elder care, wound care, end-of-life care is where it's at?
I don't think you can do convincing. I think...
Because it's not for everyone.
No, it's not. It's tough. You have to know yourself. You have to know your boundaries. You have to know your capacity. For me, I get thrill not having all of these tools available, but still being savvy enough to treat my patient on the road, right? Mm-hmm. I would never be able to work in the ER. Nope, can't do this. I don't know what I'm doing. This is too stressful.
Oh, wow.
So it's really, I think for people that are looking for something that's not bedside, but not a desk job, and wants more connection with their patient, it'd be something to look into. If you are comfortable with your skills and your knowledge, you have that compassion, you're comfortable having difficult conversations, and you're looking for something kind of out of the norm, off bedside, I definitely say give it a try. Or come with me. I love having people come with me and just seeing what I do. I've had a couple of the new nurses go with me. I've had the floor nurses be interested in learning more of wound care. So I love bringing people with me and showing them my work and what I do and how I take care of these patients. So I always say, just come with me if you're curious.
Oh, and that's awesome. I think something that we're evolving here at the hospital is that we want to be a teaching hospital too. Mm-hmm. So I think that's very neat that you're willing to take people with you on your adventures.
Yeah. But I also feel like that's the culture that we have here at the hospital and at the clinics is, if you want to learn something, go ask. Mm-hmm. Like, if I wanted to learn something in the ER, I could go and I'd say, hey, I'm really interested in learning more about this. Go to Dwayne. Dwayne can teach you so many different things. So I feel like we have a lot of, what's the best word? I don't think fluidity is a word, but that we can kind of intermingle and go into different...
We're trying to grow our own everywhere.
Yeah. I get to work with the nurses on the floor, even though I work at the clinic, and I get to learn a lot of what they do and understand, and that makes my job better. Mm-hmm. If I understand what their day looks like and the work that they do, I want to be able to support them and not make their job harder when I come in and do wound care or when I come in and do an end-of-life consult. I want to understand what are they doing for this patient and how can I assist. I don't want to hinder anything. I don't want to make it harder. So understanding and being respectful of all of the different roles that this hospital has is truly important, but I feel like we do a really good job at it.
I agree.
Yeah.
So if somebody needed your visiting nurse services or end-of-life care, how do they get a hold of you?
So I technically have an office phone. I don't sit in the office very much. So best way would be calling the clinic and asking for the wound care nurse, the end-of-life care nurse, the hospice nurse, Bre, and you should be able to get in touch with me. Brenda will get you in touch with me. A lot of the nurses here at the hospital know how to get in touch with me. My cell phone number is all over the place if you can find it.
And so if somebody calls the clinic and they don't get a hold of you right away, that's okay because you'll get back to them?
Yes, I'll get a message. And once I have, if it's not coming directly from a provider, I have a lot of referrals coming in from the city. We just call, get connected, see what that patient needs, and go from there. Like I said, if somebody needs something, we will make it work. We will figure out how to get that patient care in this community.
That's amazing.
Yes. So typically when I get a referral, we're connecting with the patient if that's possible. If not, we're connecting with the family, the caseworker, kind of getting a good idea, and then making sure we're established with Park Health. If they can't come into the clinic, which we've had multiple times, there's patients that are already homebound and they can't get into the clinic. Our providers are really good about doing home visits with me and going out and establishing care for a patient so that they can be on service. So there's barriers, but we work around them. We figure it out.
That's incredible.
I love my
I didn't
team.
know that.
Yes.
That's really special.
I've had every single one of my providers at Park and Stratton come with me to establish care and go see patients.
Awesome.
Yes.
So, if you could leave our community with one final note about either end-of-life care, visiting nurse, what would you like to tell them about your service, yourself?
Just come talk to me and ask questions. I love to educate. So if you think you have a silly question or you are interested in what it looks like, what I can offer, what your planning looks like for the end of your life, I'm more than happy to have those conversations. And I always say, like, it's never too early to discuss these conversations. And when we start those conversations early, again, it becomes less scary, less taboo. End-of-life care is not just morphine and Ativan.
Yeah. Well, I'll say that's one thing that I think I've learned throughout this conversation is that, because for me, just thinking about it, I don't want to talk about my parents' end of life or, somebody close to me, but that it sounds like if you do have those plans, that not that the passing is easier, but that you have a greater understanding of it, which maybe allows you to have just a little more peace with the process.
Yeah, and I feel like the more that you know, okay, so as a patient, the more that you're able to verbalize, this is important to me, this is what I want, and make those wants and wishes known to your family members or to your loved ones, it makes it so that those loved ones don't have to answer those tough questions. You've already answered those. They are responsible for carrying out what you've stated your wishes are. And it's important, especially when that time comes and it's so stressful, it's so emotional. We're here to remind you, hey, your dad already said this is the things that he wants. Let's do that.
Yeah.
He's already said it. You don't have to make that choice. It's right here. We're gonna honor that and we'll work to honor those wishes. So it's important to make those wishes known. And then it's important as a family member or caregiver to carry out those wishes.
Yeah. Wow. Well, thank you so much for
You're
being on the
welcome.
show today. And thank you for just the incredible service that you offer because, again, like you said, it is taboo or scary and not something that we want to think about or talk about.
Yeah.
But critically important. Everybody that's born dies. And I feel like we just leave it locked in a closet until it happens. So thank you for teaching us more about it because
Absolutely. Thank you for giving me the platform to speak on it and try to try to have more of those conversations around death and dying. It's an important conversation to have, and I'm very happy to have it with whoever wants to chat with me.
And whether we like it or not, our community as a whole is on the older side.
Yes.
And so I know that there are probably just so many, not just patients, but family of patients that need to hear this.
Yeah.
So that they can just at least have it in their mind that these conversations should happen and there's somebody to have them with.
Yeah. Yeah. And even if you know the conversation needs to be had and maybe you're not comfortable approaching it, making an appointment with the provider and with me saying, I need help having these conversations, or just calling me and say, hey, I have a loved one and I think this topic needs to be addressed and I just don't know how to do it. That way I can get a rapport with the patient and the family and we can start having those conversations. And then when it comes and they need my service, we already know what they want.
Yes. So also real quick, I know that at one time you were collecting names of people that
Yes.
offer private care. Can you tell us a little bit about that list or how people can get on it?
Yes. So I reached out obviously I'm affiliated with the Visiting Nurse Service and Kit Carson County Health District, but this list is not affiliated with that. I just reached out into our community trying to find people that provide care, whether that's activities of daily living, showering, bathing, eating, meal prep. Even if somebody is available for driving to and from doctor's appointments or going to pick up groceries, I really am just trying to reach out to the community because I know there is a lot of members that do this on the side to be able to give families that need that person that resource. So I'm always happy to get your contact information and place it on this list if you're willing. To share it with these families and our community because we're only as strong as we are with, the people that we have. And that's kind of the nice piece of pulling together in a small community is having those people that are available. They take care of payment. I have no idea how much those people charge. I'm not affiliated with any of that. It's just truly a resource of people that I've gotten together. So if anybody wants that list, again, contact the clinic and I'm more than happy to get that sent out.
Yeah, or if you'd like to, I call it Bre's List. If you want to be a provider on Bre's List, then reach out to Bre and have that conversation with her and see if you're a good fit for that.
Yeah, a lot of people have reached out to me on Facebook. Again, my number floats around all the time, so you can text me. Again, if you don't know how to get a hold of me, just get in touch with the clinic. And Public Health also has that most recent list of the private paid caregivers. That's what I call it, the private paid caregivers.
Gotcha.
So again, the financial piece and what you're looking for, you can discuss with whoever you choose to call on that list.
Yes. Again, a reminder, that list is not affiliated with the hospital, but it's just a piece of
a community work. Just a community resource to help the patients that we care for.
Yeah, which is awesome.
Yeah.
Well, again, thank you so much.
Thank you.
Have a great day.
You too.
And thank you guys for listening, and we will see you next time on the KCCMH Connection. Bye.
Bye.